Are you having knee pain with standing, walking, or going upstairs, and you're over 40? Watch this video. My name is Dr. Nick from Preferred Physical Therapy, where we specialize in helping people over 40 stay active and independent, live free from painkillers, and avoid surgery. I'm going to go over some basic knee anatomy to help you understand where you might be having pain on your knee and what conditions those might be. I'll also go over basic and normal knee movement to help you perform easy at-home self-assessments. And I'll give you easy exercises you can do at home to help improve your strength and your mobility to combat the normal processes of aging that contribute to more knee stiffness and knee weakness. So we're looking at a right knee. This is the femur or top of the knee. This is the tibia or bottom of the knee. We know this is the right knee because this little bone here on the side is called the fibula. The fibula is a non-weight bearing bone, meaning we don't bear any load through it. It provides an important anchor or landing place for a lot of muscles of the lower leg. This right here in front is called the patellar tendon. This is the kneecap. So we flip it over upside down. This is the kneecap. Inside here on the side, this is the lateral side or the outside of the knee. Again, fibula is on the outside. So this is our LCL or lateral collateral ligament. This is our meniscus, lateral meniscus. And on the inside, this is our MCL and medial meniscus. Behind or backside, we have our PCL, which you see very easily, and then we just see the top side of our ACL, which then goes from back to front and lands in front. So those are the four major ligaments that help stabilize our knee. Ligaments connect bone to bone. Uniquely important. Tendons, this here, connects muscle to bone. So you can see this is clipped as if to demonstrate all of our quad muscles. So we have vastus medialis on the inside, vastus lateralis on the outside, we have rectus femoris, and then vastus intermedialis. These are the four muscles of our quad that then taper and all connect into this big, thick tendon that encompasses or envelops our entire kneecap or patella, and then tapers down and inserts onto this, what we call tibial tuberosity. Any tuberosity is a spot of bone where tendons insert on. What's also unique and we don't see here are bursa sacs. Bursa sacs are little fluid-filled sacs of synovial fluid. Synovial fluid is a highly specialized joint fluid or joint oil. They lubricate and nourish joints. And they're little redundant reservoirs that help to cushion and soften parts around the joint that have friction. So we have friction around moving parts, so tendons and some bony joint surfaces. Also unique, what we don't necessarily see real well, is the features of bone. So as I remove the kneecap and look straight in, the end of the femur has this valley here, and that's where the kneecap will sit into. So if you can see from a top-down perspective, these unique bony surfaces will lay right inside this valley. And what that's going to be able to do is as we bend that knee all the way down, it's going to stretch and keep that kneecap inside that groove. Now, why this is important is if you have pain right over your kneecap, if this is my right knee and I'm looking straight down at it, this is how it will look. If I have pain around my kneecap, sometimes I have it right underneath where this patellar tendon is. That's typically jumper's knee or patellar tendonitis. If I have knee pain right on top of the kneecap or even on the side of the kneecap, we often will hear about patellar chondromalacia or a softening of this bony surface underneath. And that wear and tear of that joint surface can contribute to arthritis, but also some softening of the bone. Patellar chondromalacia is a lot more common with our late teens and into early 30-year-olds who are runners, jumpers, playing a lot of sports that require a change of direction. Cartilage, where's cartilage? Cartilage does include some of the meniscus, but what's interesting about cartilage is it's all about the end of the bone. The end of the bone is thickened, but also cushiony. So that cartilage is different than bone, even though it looks like regular bone if we were to dissect the tissue. But on x-ray, you'll notice it's not as thick or as hard as bone, which is why when they do x-rays, we want to see joint space. If I were to look at an x-ray picture of this, we want to see a gap or an emptiness between bone edges. And that gap or space in between there demonstrates that we have good cartilage health. When doctors call this bone on bone, it means that there's not as much joint space between there, and the firm, bony surface of these tissues are now close together. The closer those bone edges are across a joint, the more painful they'll become, and the closer they are to needing joint replacement. These meniscus are very unique. The lateral meniscus is more O-shaped. It's almost continuously in a circle, and that's because there's a little bit more pivot that goes on with this joint. The medial meniscus, or inside meniscus, is more commonly torn. It's more C-shaped or wider around the edges, and that's because there's more movement as it pivots more singularly on the lateral aspect. It needs to rub and move differently on that medial aspect. It gets torn a lot more and is a bit more responsible for load bearing, and so we'll see a lot more medial decay or medial breakdown of that knee because of how much more weight bearing there is through the inside of the knee. The joint has two motions, and many folks forget about the other one. The first motion is bending and flexing. So it will bend and it'll straighten. Often we think about it as being a hinge joint. It's like a hinge in a door. It just moves in this singular motion. The reality is there's also a pivot or roll to it. And so it does a little bit of this pivot and roll. That helps to facilitate that bending of the knee. So often folks will overlook the fact that if we get really stiff with pivot, we're going to have a hard time with bend and flex. So if you have a lot of pain over the inside of the knee, particularly just to the inside of the kneecap, often you can kind of feel where it might be soft in between two firm bones. If you're having pain along that ridge, that usually is indicative of some kind of meniscus injury. It could be a small tear, it could be some bruising, it could be medial collateral ligament sprain. If you have pain on the outside of the knee, it could be along this lateral meniscus. If you have some pain over the outside of the knee, often it's because of this meniscus or some cartilage damage that occurs because of the pivot being a problem. Pain on the inside, just below the knee joint itself, could be from Pezanserine bursitis. We see that very often, particularly if you have pain or sensitivity along the adductor muscles. Those are the muscles that run along the inside of the thigh. Folks often will be surprised that they didn't even know they had pain along this ridge. And so as we identify that there's pain on the inside, just below kneecap, but just on the inside of the shin bone, and then we run our hands up the adductors of the thigh, they'll be surprised at how much discomfort they have along that line. If I flip it over and we have pain on the backside, this is where a big bursa sac will exist. This bursa sac on the backside is usually irritated, and when irritated, called a Baker's cyst. A Baker's cyst is just a fancy way to describe some irritation and inflammation causing this bursa sac to swell or inflame. That is often indicative of some kind of injury to the inside of the joint, because that's the pocket where a lot of that inside joint synovial fluid will pool and collect. So if there's any swelling to the inside, it'll collect there and be painful and irritated. Very easy to find out. If you got pain there, just reach behind, kind of rub your fingers from bottom to top and kind of scrape along the backside. And if it's tender or painful there, and you feel a little puffiness to that backside, that's a Baker's cyst, and you probably just need to get some of that swelling taken care of. ACL and PCL injuries are more commonly associated with some kind of athletic or traumatic event. Not necessarily exclusive to an outside trauma or blunt force trauma that causes a tear. It can also happen with a hard cut, what we call a non-contact injury. Those are very, very common, but you often will know right away if you have some kind of ligament tear to the inside of the knee because it will feel very unstable, meaning that it'll feel loose or you'll go to move and it'll give away. Those kinds of things are indicative of you might have something more involved there. Plus you get a lot of swelling around the knee when these kind of cases happen. They're more traumatic and more acute, meaning that they sudden onset presentation versus a chronic. Every now and then we do have a chronic failure or a chronic tear of ACL, but it's not that common, and it usually is because we've had significant arthritic decline or arthritic presentation of the knee. The PCL, not commonly torn. It sometimes will if we fall on our knees straight down. It'll either bust up the kneecap or it can cause enough shearing across the tibia to then pull it away from the femur to cause that PCL to tear. Sometimes we've had folks in car accidents where their knees will hit the dashboard, and that can cause a shearing force across the knee enough to tear the PCL, but not that often. And a lot of folks can do okay conservatively without having to surgically repair the PCL. It's not as crucial as the ACL is. So an easy self-assessment to identify if you have any restrictions to your knee movement is to lay on the floor or a flat, straight table like this, and we want to see about extension. Extension is vitally important. If we don't have all of our extension, then every step we take, we're getting more shearing forces across the kneecap into that patellar groove that I showed you that now is wearing down more and more of those femoral condyles or back at the patella. So it's all the cartilage on the back of the kneecap and onto the femur bone. So an easy test, lay out straight and flat, and I want you to contract your quad or straighten your leg and try and pop your heel off the table. Now you notice my leg is still flat, but I'm able to get a couple inches off the ground. That's how you know you're good. About 5 degrees is what we consider to be normal. And as long as you can get a couple inches off the table, that's 5 degrees. My right one, we want to be able to get all the way there. Sometimes that's a joint stiffness problem. Sometimes it's a muscle activation problem, meaning that we don't have the strength at end range to get all that to pop up. So we'll show some exercises to help with that. Now, to make sure you have enough knee bend, just lay back, pull your heel back. If you need to, bring your hands in and squish your heel all the way to your rear. You should be able to get it pretty much all the way there. So bring it in. Your heel should be able to touch your rear. If you find yourself having to stop anywhere along this route, that means we have a lot of restriction through the knee joint itself or across the quad, both of which need to improve in flexibility to keep those tendons and active stabilizers elastic. The more elastic they are, the less pressure and wear and tear we're going to introduce into our knee. Grab down near the ankle and pull it in towards your rear. For your first exercise, just get a pillow, a small pillow or a beach towel and roll it up so it's nice and thick. And we're going to work on that little bit of extension. This should be pain-free. If you're having any knee pain currently, then we want to work on flattening our legs, squishing it down to the pillow, and kicking our heel up off the table, holding 3 to 5 seconds, and doing this 10 to 20 times. Hold 3 to 5 seconds, and come back down. We're working on what's called terminal knee extension. That's the extension necessary to keep it strong and sturdy at full extension. Vitally important for walking. Every time we go to walk and we bring our foot out to step, we want to land with our heel first. Our heel first is called initial contact. And if we're not sturdy with our active stabilizers across our knee, we're going to continue to shear and wear down our cartilage at our knee. So vitally important that we have full extension and strength at terminal knee extension to slow down the arthritic progression with every step. This is called short arc quads. 3 to 5 second hold, 2 sets of 10, and we're doing it on both sides. If you have pain anywhere along this move, then I want you to stop where you have pain and hold 3 to 5 seconds. So if getting all the way to the top is painful, then go right to where you can without pain, stop there and hold 3 to 5 seconds and see if we can't get a little bit further each time. All of these exercises are 4 to 5 times a week. All right, the next one, same position. The next one is a bridge or a heel dig. We want to work the hamstrings. Hamstrings are the muscles responsible for bending the knee back, but they're also responsible for slowing down our leg as we step forward. So every time we throw our leg out in front of us to walk, our hamstrings are the ones slowing that down. It's often overlooked. We seem to get really quad dominant with a lot of our exercises, and so our hamstrings are very important that we maintain. Dig the heels in and just begin to lift. Hold 5 seconds, and then relax. Repeat that 10 times, doing 2 sets. As that gets easier, we want to move to a full bridge. In a full bridge, our feet are flat on the ground. Our back is going to be flattened out, and we're going to squeeze our glutes and our hamstrings to raise our hips and pelvis off the table. Hold 3 seconds, and then relax slowly, come on down nice and smooth. What we don't want to do is go up fast and then to kind of flop down uncontrolled, but we want to be under control the entire time. So to demonstrate the bridge, once the heel digs get too easy, we're going to flatten our back out, squeeze the glutes and hamstrings. Glutes are our muscles in our butt, and then our hamstrings are going to help to lift us off the table. Hold 3 seconds, and then come back down slowly. We're going to do this 10 times, twice. So flatten out first, squeeze, lift the glutes and hamstrings. There should not be any pain in the knee. You should feel this along the backside, glutes and hamstrings. If you're having difficulty with bending the knee and it's stopping somewhere before you're able to hit your rear with your heel, get you a strap. This could be a dog leash, beach towel, or bed sheet. Put it underneath the foot. I like to crisscross in front because it helps to lock in the ankle. You're going to lay on back. You're going to pull it back as far as you can, and then you're going to squeeze into it a bit more, put it back on the table, and you're going to hold 10 seconds. At the end of 10 seconds, push it back out, and then use the straps again to help pull and squeeze it in. Hold 10 seconds, do this 10 times. I like the crisscross in front because if it doesn't, there's a tendency where it can slide up the back of the heel as I pull, and then it's not as effective. So we crisscross in front, and as you pull, it stays nice and sturdy. 10 seconds, 10 times to increase knee flexion. The next one that we're going to do for our hamstrings, but also for that pivot motion I was describing earlier, is as we sit here on the edge of a chair or a low table, you're going to bring your legs out in front of you mostly straight, and you're going to curl or turn your toes inward. So this is my left leg, I'm turning my toes to the right, and then I'm going to push into the ground and scrape backwards, and then pull it back forward, all the way straight, turn inward, and then scrape backwards. This is working the inside hamstring muscles, as well as helping to improve the pivot of the tibia on our femur. This is going to help with motions of knee flexion and extension, as they both need a little bit of that pivot to reach their full potential. So we're going to do 15 twice. And the more pressure you put into the ground, the more drag and friction you create, the more resistance that you'll have. This should not be painful. It should be challenging enough where you start to feel a little bit of a burn on the inside of the hamstring, meaning the muscles of the inside hamstring are working. There's 2 muscles on the inside. 15 twice. The next one, if you're having a difficulty straightening your leg, so you couldn't quite get your heel off the table as we were doing that self-assessment, this next one is vitally important for you. You're sitting down at a chair, bring your leg out in front of you as far as you can. If you're on a couch, come to the edge of the couch or the edge of the chair. And what you're going to do is put your leg out as straight as you can. Then you're going to bring your hands and overlap them so that your thumbs are on either side of the leg. Bring it as close down to the knee as you can, not on top of the kneecap, but just above the kneecap. Big and tall, straighten your back out and bring your sternum down to your kneecap. As you do so, you're going to push straight down or back to get a little bit more extension through your knee. So both hands right on top, push down and back, lean forward, hold 5 to 10 seconds, repeating this 10 times. And then you can relax out of it. We're going to mobilize and improve that extension. This way every step gets more and more comfortable as you straighten your knee. The other set of muscles that we're going to talk about are our gastrocnemius and soleus. These are our calf muscles. There's 2 parts to it, and they're vitally important in assisting knee extension and knee flexion. You're right, I said knee extension because the calf does help with knee extension. Knee extension is a straightening of the knee, and it happens if I'm like this and I'm loaded. If I push my toes in the ground, it's going to pull my tibia back. That's knee extension. So the calf and soleus, in this particular case, the soleus is more important at assisting or participating in knee extension, because as I'm bent in the knee, my gastroc, or the calf muscle higher up in the leg, is not working as much as the soleus, which is the lower leg muscle. And if I'm here, it's going to push toes down like I'm stepping on the gas in a car, and that's going to assist in bringing my knee back. We want to have strong calves and strong soleus muscles. The way that we work the soleus independently or uniquely is if we work it in sitting. So we sit down, bring our legs underneath us enough to where our knees are on top of our toes. That produces what we call dorsiflexion, or a bend in the ankle. And then we're going to raise our toes up all the way. Now what's so important is we want to reach all the way to the top and squeeze at the top. That squeeze at the top, that's where you're really going to feel calves working. And we're going to 1 to 2 seconds at the top and rep this out nice and smooth, doing 15 reps twice. Holding 1 to 2 seconds, but really feel it squeeze at the top. I see a lot of folks who don't work their lower legs or calves, getting a lot of knee pain and having difficulty with walking, with stairs, and balance. This is a group of musculature that's vitally important to maintaining our mobility as we age, and it's often overlooked. To make this harder, you can get dumbbells and rest dumbbells or jugs of milk or water on our thighs to get a little bit more load. You can lean forward and rest your hands on your knees and do the same thing to push down and get a squeeze at the top. We're doing 2 sets of 15, holding about 1 second to 2 seconds at the top with a big squeeze. The next one is you want to find an area of a blank wall that you can lean into that's sturdy, safe, and not going to be a problem. You're going to lean back into the wall with your legs out in front of you. Now, how far out in front of you? Maybe a half a step, depending on how much resistance you want. The further away from the wall your feet get, the more resistance you're going to have. So if you need to start a little bit closer in, just to kind of feel if that's going to be an appropriate load for you, that's totally fine. Start where you're most comfortable. Because what we're going to do is, as we stand and lean into the wall, we're going to push our knees straight and then pull our toes up. We're going to work the muscles on the front of our shin called the tibialis anterior. And a lot of folks will question how this muscle has anything to do with our knee health. And to explain that, I'm going to help you understand why in walking, this gives our knees so much support and relief. Because every step that we take, we land with our heel out in front of us and our toes pointed up. As we load this, our anterior tib and quad, the muscle down the front of our shin that we're exercising, and our quad are active stabilizers through this motion. What helps me to then slowly and safely come forward and load the leg and knee is that anterior tib. We go from a dorsiflexed or toes up position into a plantar flexed or neutral position as we walk. If we have weak anterior tibs, this falls forward and then our knee bends and we have to land and slide forward. They'll walk flat-footed because they have no strength in their quad at terminal knee extension, or they have no strength in the anterior tib muscle that then forces them to bend the knee quickly. The more quickly they have to bend their knee as they step, the more shearing and grinding we get of the backside of the kneecap across the femur. That contributes to the accelerated progression of arthritis. So to save us from that, we want strong anterior tibs down the front of our shin and strong terminal knee extension. This exercise works both of those. So the closer into the wall we are with our feet, the lighter the load. Find an appropriate amount of load for you where you can do 15 repetitions twice. Give yourself a little bit of break in between. You'll notice I like to dose a higher amount of reps to learn the movement. Keep the load fairly light so that you can perform 15 reps. Then we can dose a little bit heavier within that load. The reason why we don't go like 6 to 8 reps is because this is not a big, strong power mover. This is an endurance, this is a marathon mover. So we want to train that way. So we do a higher rep count with the intention that we need to take 7 to 15,000 steps a day, and these muscles participate in every single step. Back flat against the wall, knees straight, pulling the toes up, and we're going to do this 15 times. A small pause at the top just to get a squeeze. "15 times twice. The next one that we're going to do, stay right here at the wall, bring your feet out just a little bit wider, just outside of hip width, toes right at noon, and we're going to work a wall sit. A wall sit is an isometric hold or no movement hold to work on our quads, hamstrings, and glutes. And the way that we're going to do that is we're going to find how far down we can slide without getting more knee pain. If you find, oh, right here I'm a little bit painful, but if I move up a little bit, I'm less painful, great, and that's where you start. And we're going to work on going from 10 seconds to 30-second holds at one time. So I want you to start where you're most comfortable. If you're finding that at 10 seconds you need to get out of this because your legs are shaking or you're getting really fatigued, that's totally fine. Then come out, take a break. We're going to work a few more reps. So we went over basic knee anatomy, appropriate knee movement, and a list of exercises that you can do to help get back to standing, walking, and taking stairs without pain. These are perfect for our folks over 40 who have had a history of knee surgeries or knee injuries that are now noticing more and more restriction within their knee, causing them pain with everyday activities. If you've been told you have arthritis or you're bone on bone, these are perfect for you to help you nourish your knee joint and slow down the progression of arthritis. These exercises are perfect to help maintain and even improve your current knee mobility, and great for anyone who's looking to avoid surgery, pills, or injections as a way of relief from knee pain. The biggest thing to remember is if any point during these exercises you're finding pain, that's the spot where you want to stop. This is not one of those go crashing through that pain and feel like some is good, more has to be better, and you're going to try harder, and you're going to try harder and harder to get past that pain. Pause that thought and just go into that spot just before it gets uncomfortable, just before it gets painful, because that's where we want to work. We don't want to restart or cause more pain and get into this pain cycle where now we're having more and more irritation into the knee. So just proceed slowly and cautiously into that point of pain and stop there. If you found any of this video helpful, click the link below to download my ebook titled 7 Quick and Easy Ways to Stop Daily Irritating Knee Pain. For more effective videos like this, please consider subscribing.
Instead of in this video, just